very good afternoon to you all. On behalf of the Postgraduate Institute of Medical Education and Research, I welcome you to this Webinar-6 on mental health issues during COVID-19. We have an esteemed panel of experts with us today, but before proceeding any further, I would be connecting you to Professor J.S. Thakur, who is the chairman of the PGI Committee on Prevention and IEC related to COVID-19. So we will be taking a short message from Professor Thakur.
So very good afternoon to all of you. On behalf of the PGI, it is indeed a pleasure for us to welcome you to the Webinar-6 series, which is being organized by the PGI Chandigarh. Today is a very important topic. What are the mental health issues during COVID-19? We all know that there is a lot of fear, stigma, stress, anxiety, and some of the people are facing depression during this pandemic. So we thought that it is very important to cover this topic. We have a very eminent panel of speaker today, Professor S.K. Matu, who is the head Department of Psychiatry, Professor Basu, who is also the professor in the same department, and Dr. Shubh Mohan Singh, additional professor in the same department. So on behalf of all of you, I welcome the speakers and without wasting much time, hand over to the speaker and Ruchita, who will be moderating this session. Thank you very much.
Thank you, Professor Thakur. And now we are starting up with our scientific schedule. And the first talk of the day is by Professor S.K. Matu, who is the head in the Department of Psychiatry at PGI Chandigarh. And he would be talking about psychological care of patients having COVID-19. All the way to Professor Matu.
Thank you, Dr. Arpit. Good afternoon, everybody. Although the title of my presentation says mental health problems in patients with COVID-19, the fact will be that I'll be trying to cover the mental health problems not only of the patients, but everybody else too. The scope of the presentation will be to deal with the stress caused by COVID-19, the vulnerability factors, the manifestations, and what can be done by individuals, families, carers, including professional carers and society in general, and how professionals can help, and lastly, a few of the useful links to get information. COVID-19 is stress-inducing as a pandemic because of the uncertainties associated with it. One, there is no definitive treatment or vaccine. It is highly contagious and everybody is at risk. Initial symptoms, if present, will mimic common cold, which will lull people into complacence. And then lastly, there will be asymptomatic carriers who are an unknown risk, unseen risk. The public management of COVID-19 has been primarily in the form of isolation, quarantining, and lockdown, which involves anybody from one individual to a family, to professional carers, to small localities, to entire nations. The reasons for vulnerability are rumors. We all jokingly refer to WhatsApp University. Anybody wants to say anything, that person passes on the information, and it is not screened all the time. Our daily lives have changed, daily routines have changed. Locking in inside the houses has led to another problem of boredom. And with plenty of time on hand, people are worried about the illness, its implications for their daily needs, finances, job, and in case people are suspected, discrimination, prejudice, and stigma, which they see prevalent all around them. This in particular can lead to a sense of alienation, wondering as to where the person belongs in terms of the relationships, and in the interpersonal sphere, it can lead to a strain in relationships, which has already been recognized as domestic violence or workplace violence. How does this stress manifest? The commonest syndrome is one of anxiety, beginning with the so-called worried well people who simply brood over things as to what's going to happen. And this range of percentage indicated is tentative and cannot be said to be final because it is not based on a large research data. The second, and these worries will then lead to a second syndrome, that is of depression, comprising mood changes, depression, sadness, which then can progress to feelings of helplessness, hopelessness, guilt, and social and occupational withdrawal. Common to anxiety and depression syndromes is irritability, poor concentration, poor attention, poor sleep and appetite, and sometimes also abuse of substances like tobacco, alcohol, and other substances. And it might progress to feelings of suicidal tendencies. And lastly, there might be behavioral problems, as I referred to earlier, in the form of domestic violence or workplace violence. A long-term complication can be post-traumatic stress disorder. Once a patient is diagnosed with COVID-19, then the risks of mental health increase because there are fears of infecting others, which are genuine, especially for near and dear ones, family members, or co-workers. There is actual or perceived stigma displayed by the community in general. There may be guilt and worries related to the future of the family, especially in the context of death occurring, the roles and duties of self and others, and economic and other future of the family. These worries can lead to a sense of helplessness, hopelessness, and frank depression. And this all falls within the realm of what more than half a century back was described by Elizabeth Kubler-Ross as a reaction to loss in the form of denial, anger, bargain, and lastly, depression. So what are the signs that one can look for before deciding that somebody needs help for these changes, problems, issues related to mental health? Any significant change in pattern of sleep, appetite, or activity, a change in the usual pattern of desires, pleasures, and related activities, excessive use of tobacco, alcohol, or other substances, mood changes which are excessive in the form of irritability or sadness, persistent and severe negative thoughts, and then clearly enunciated suicidal thoughts, gestures, or attempts. These will be the red flag signs which indicate that a person needs help. What is to be done under these circumstances? The most important thing is the awareness. A person must be aware that mental health issues can emanate and arise, and therefore they need to be recognized as early as possible before they can be attempted to be addressed and corrected or managed. So one has to look for feelings, thoughts, and conduct of the persons involved. One has to encourage that person must talk the problems out to near and dear ones, and if then required, to professionals. This can be achieved through maintaining contact through phone calls, video chats, email, and social media. And in case a person is diagnosed and therefore isolated and quarantined, these restrictions of isolation and quarantine must be minimized as much as possible. It is important to maintain a healthy lifestyle during this period through a regular routine or maybe adapting new routines of daily living. These routines can or should include physical activities, exercise, yoga, daily chores, and also creative or recreational activities like music, singing, dancing, painting, games, or other hobbies specific to the individual. One must take care of healthy and balanced diet, adequate and good sleep, for which principles of sleep hygiene may be followed. And lastly, interaction with others, which is healthy and positive, although with maintenance of physical distance. Specific skills to cope and relax under these tense situations are, if possible, one should look at the previous life experiences to identify adverse situations which were coped with successfully. And based on that experience, recall the skills that helped. And again, these will be, as referred to earlier, activities like music, reading, games, prayers and meditation, relaxation through dance, exercise, yoga. And some people say what helps them a great deal is maintaining a stress diary on a daily basis and analyzing it on a regular basis. Lastly, a strict advice is not to use tobacco, alcohol, or drugs to overcome these worries and stress related to COVID-19. Advice for family members of persons with high risk is that one should be careful that the risk is much higher in children and younger and older adults, especially for those who are impaired through sensory, motoric, or cognitive deficits and are partly or largely isolated. The ways to help these people especially are that information must be shared with them in simple language that they can understand easily, to explain to them as to what is happening, what is going on, to advise them and train them how to reduce the risk through social distancing, hand washing, and personal hygiene. And sometimes this is helped or done better through pictorial and written information rather than verbal instruction. As far as possible, the whole family should get involved in such information sharing, leisure sharing, rather than one or two members being loaded with this responsibility. The whole family or subgroups can engage in routine activities, recreational activities, and cognitive exercises, especially for the elderly. Those with long-term health conditions or health problems need to ensure access to their regular medications and medical help. And also everybody should know what to do in case help is needed. For example, a taxi, food delivery, medical and fire services, or an accident. Information is crucial and credible sources should be trusted rather than, as I said earlier, WhatsApp University. But also at the same time, if there is a risk of upsetting oneself, then media involvement should be limited or restricted. These are some of the links which can be tapped for getting credible information from international level to national level to our institute level and our departmental level. Major don'ts and do's are listed here. The main don't for professionals is that we should be respectful and not demean the patient by calling them a victim or victim family. Rather, they can simply be referred to as people who have COVID-19. And also be careful not to link any particular religious, ethnic, economic class group to this disorder or its spread. The do's advised are that one should try to protect oneself and support others. one should be positive and hopeful in narration to others, and perhaps those who are caring for others can be honored at a societal level. Anybody who is in need can seek help. Anybody who feels overwhelmed can seek or should seek help, especially if the pre-existing mental illness or substance use disorder is getting worse. And everybody should have a plan how to do it, when to do it, and where to get it from. Our telepsychiatry services run from 9 to 11 a.m. every day. People are registered, given a registration number. Then their issues are discussed at a team level and final decision for management taken. And then they are advised the further care. I'm presenting here a brief of the data that we have collected. Our crisis helpline over about a month has received 400 calls, out of which 45% calls were related to stress and anxiety in the context of COVID. Our telepsychiatric services over 3 weeks received 58 calls. 10 of these were from new patients or new callers, and 4 out of these related that they were anxious about COVID-related issues. Among 44 inpatients who are positive with COVID-19, there has been 1 psychiatric referral received by our department. In emergency outpatients, out of 4 patients who reported with self-harm, these included 2 with substance use disorders. I am presenting this data to emphasize the fact that COVID-19 must not be taken lightly, and it can have serious implications for mental health. Thank you.
Thank you, Professor Matu, for such a comprehensive insight into the psychological care during COVID-19. And before we connect with our next speaker of the day, who is none other than Professor Basu from the Department of Psychiatry, I would like to apprise you all that you can send us your questions through the live chat, the YouTube live chat which is going on. You can very well post us your questions, and we would be taking your questions with the answers of the experts in the panel discussion at the last. So we are breaking here for less than a minute, and we would be back with Professor Basu, who would be talking about substance abuse and COVID-19. So welcome back, and we have with us Professor Basu, all the way to Professor Basu.
Good afternoon. Today I'm going to talk about substance abuse and COVID-19. As you know that this is a big issue these days, but since we have I expect that we have a mixed audience, I thought that we'll spend one slide on the 2 key terms, substance and abuse. So substance, or a short form of psychoactive substance, is any chemical that acts on the brain, alters mental or behavioral functions, induces pleasure, at least in the short term, and tends to lead to addiction if used repeatedly. The licit substances are tobacco, alcohol, I've not mentioned caffeine here, and also prescription drugs. The illicit substances in India would be many of the illicit opioids like opium and heroin, cannabis preparations except bhang, cocaine, etc. The term abuse, on the other hand, is not a medical term any longer. It's more of a popular layperson term which still survives, but it generally refers to the problematic use of licit substances or any use of illicit substances. So a person may progress from casual, recreational, once a while use to more of a hazardous use to harmful use when the substance use starts causing actual harm in his or her life, to a pattern where his life depends on the substance use. So these two, harmful use and dependence, are clubbed as substance use disorders, or in a rough sense known as addiction, although we don't tend to use the word addiction because of its pejorative connotations. We all know that excessive use of substances can lead to physical, mental, and social problems. Now, why COVID-19 is bad news for people living with substance use disorders? The first and the obvious one is the disease, of course, because COVID-19 is bad news for people with substance use disorder, and vice versa. Substance use disorder is bad news for people with or likely to contract COVID-19. We'll elaborate upon this in a minute. But more importantly, at times and paradoxically, the cure in the form of lockdown, in the form of social distancing, which inevitably leads to unavailability of substances, even the licit substances like tobacco and alcohol, can create problems. As we have seen from the recent newspaper cuttings, ever since alcohol has been not available for about 40 days now, since 25th March, the lockdown, there have been studies of liquor getting stolen from vends, bootleggers hitting new high in Punjab amid lockdown, and the rate list going up and up, although they are available through different channels. States across India witnessing surge in even suicide cases due to acute alcohol withdrawal symptoms in various places, from severe alcohol withdrawal causing hallucinations to palpitations. They hit the tipplers, and even at one time Kerala thought of giving alcohol on medical prescription to very severe alcohol dependent patients, although later that has been withdrawn. But Meghalaya, I believe, still does that. And interestingly, despite lockdown, there has been no decline in heroin smuggling from various places. It's only that the prices have tremendously gone up and reflected in the SOS calls to the drug helpline in various places. And people have been attending the various opioid clinics, flocking to them, in fact, because of decreased availability. So you can see that it has caused a tremendous amount of problems in the states and in the country as in general. So there are various underlying chronic medical conditions which a substance user or a chronic heavy substance user suffers from, which make them either more likely to contract COVID-19, or if they have one, then they make them progress to the worst prognosis, like COPD and other lung disease, cardiovascular disease, immunocompromised state, liver disease, cognitive impairment, all being worst prognostic indicators for COVID-19. There are some acute effects of intoxication or withdrawal, like respiratory depression or pulmonary arterial constriction, which does not help the progression of COVID-19. Interestingly, acute opioid withdrawal can mimic some of the COVID-19 symptoms and can make the diagnosis at times difficult, like severe aches and pains, mild fever, running nose, loose motions, severe malaise and fatigue, and occasionally some shortness of breath. You can see that there's an overlap between these and the typical COVID-19 symptoms, so it can be confusing. Very importantly, the behavioral act of drug taking and sharing makes COVID-19 acquisition much more likely in these high-risk population, like sharing the injecting paraphernalia, the entire series, sharing cigarettes, continuous hand-to-mouth touch, hand-to-hand touch, hand-to-packet touch, using chillum, the earthen pot for using cannabis, canny, glass, joints, everything. They make them more susceptible to COVID. And also the environment with parties and gatherings, drug use settings, crowding, the ghetto subculture in case of certain drugs, non-compliance with public health norms, and homelessness. And finally, stigma, the huge stigma which Dr. Mattu had talked about in his earlier. All these things, all these make the people with addiction problems more prone to infection with COVID, more prone to poor prognosis once they have been infected with the virus, less likely to access healthcare because of stigma and several other problems, and less likely to maintain healthcare. In summary, this is the problem in this high-risk group. And these are almost basically a collision of two epidemics, the COVID-19 and the addiction, as has been mentioned in one of the series of articles from USA, but this is true actually everywhere. So these are epidemics within epidemics. The initial days were difficult. Kerala reported suicides, as I have already talked about. They had to allow on doctor's prescription initially. There was a brief spurt of complicated alcohol withdrawal of seizures and delirium tremens, and initial articles, huge concern were raised, like these ones where people talked about the various risks and harms which we have already talked about, including ingesting non-beverage alcohol, in sheer desperation, using alcohol sanitizers, methylated spirit, and dying because of this. This Nimhans Bangalore preprint article shows that there was a sharp rise in complicated alcohol withdrawal for 1 week, for exactly immediately following the national lockdown. But interestingly, it came down within about a week's time again. In our own EMOPD data, although the numbers are not very large, but you can see that the substance use disorder clocked percentage-wise some increase in both general as well as complicated substance withdrawal over the post-lockdown period. So what to do? For people who are already positive or suspected, it is important to ask simple screening questions like, do you smoke, drink, take any illicit drugs? How much? More importantly, do you have problem quitting? If yes, what type of? Because here we are talking about withdrawal symptoms rather than anything else. In case of possibility of strong withdrawal or suffering, contact the psychiatry or the consultation liaison team. There are instruments to screen for this, but simple clinical screening should be all right. We have to remember that most cases of mild withdrawal actually should not need any specific medical management. We don't need to get overhyped or overreact about this. Other than general principles like rest, good hydration, electrolyte balance, simple fruit juices, nutrition, analgesics, antipyretics if needed, and very importantly, assurance and calm attitude, because COVID-related anxiety can actually feed into withdrawal anxiety. There are now two very important documents which are available, including one which has been released just yesterday. That's the Indian Psychiatric Society and the Nimhans document, which is more comprehensive guidance. But basically, community level is not possible right now because of lockdown, severely limited. OPD based is also severely restricted. Inpatient based has a minimal role with some expectations, so it's more of emergency based for severe withdrawal, and very importantly, telephonic, WhatsApp and SMS often useful for known patients, and proper telemedicine. The time has arrived, but there are problems. If you haven't used, don't start now. If there's occasional recreational use, quit on your own. If it's hazardous, harmful, dependent use, help can be useful in different ways. I'm not going to the details of the actual management of tobacco withdrawal. As you know, there can be non-pharmacological and pharmacological measures, of which the nicotine gums are probably the most common and easily available. Alcohol withdrawal, again in majority of cases, would be mild and self-limiting. In minority cases, will require benzodiazepines. We may prefer lorazepam because we don't perhaps know the liver function status right now. And in very few cases will be complicated alcohol withdrawal with seizure and delirium. They should be admitted or at least kept in the emergency setting for a few days with a high level of monitoring, investigations, parenteral high dose thiamine, other multivitamin, and diazepam in sufficient doses for producing mild sedations, and then taper off. Telemedicines have come to rescue, and now since the 25th of March, the same day, interestingly, when the national lockdown was imposed, telemedicine practice guidelines were officially approved. We are not going to the details of that, but it can be very useful for emergency advice and referral, for motivation enhancement counseling, for counseling using the relapse prevention principles, and many psychiatric medications can be prescribed after video consultation or repeated for patients seen in person within the last 6 months. We have, however, a problem for substance use patients, because many crucial medications for alcohol and opioids cannot be prescribed over telemedicine simply because they are either under Schedule X of the Drugs and Cosmetics rules or come under the NDPS Act psychotropic substances, like almost all benzodiazepines, non-benzohypnotics including zolpidem, most opioids including buprenorphine, and now tramadol and propoxyphene. Recently, clonazepam and clobazam have been permitted, but they are not much used in withdrawal management as such. So we have a problem. What if benzodiazepines are not available and you have to make a telemedicine prescriptions? None as good as benzos, but carbamazepine, oxcarbazepine, gabapentin, valproate, and baclofen have been used with some success, so maybe worth trying. If buprenorphine and methadone are controlled substances, but the special case is that it cannot be provided over telemedicine and patients have to come for in-person picking up of the medication. So there are multiple challenges: how to run the OST service, how to carry on an in-person medication dispensing, how to maintain social distancing in the OST clinic, how to maintain supply of buprenorphine naloxone in the context of travel restrictions, how to maintain supply to the center because many of them cannot reach the medication to the center, and how to manage the service with less than usual manpower. These are all the challenges. IPS, the Indian Psychiatric Society, has produced its IPS interim guidelines, which are available in the IPS website, and we are just in the process of publishing our own article, which should come up in the next few days, about sharing our experience and the interim standard operating procedure, which we have been using in our OST clinic. Basically, we want to now focus relatively less on diversion issues at this time and focus so that the patient can get their medications while enhancing social distancing in the OPD, maintain the service for already existing patients, enhance the duration of take-home doses up to 2 weeks, minimize service requirements, enhance flexibility in the system, and openness to revise the program based on experience. There are many structural aspects like zoning of the waiting hall registration area, staggered entry into each zone at 5 to 6 at each time, COVID screening by the nursing staff, prescription by doctor, dispensing by pharmacist, and quick exit. And we have also arranged with the Punjab government to supply buprenorphine on loan basis temporarily. Public health aspects like information dissemination have been utilized for opportunistic intervention, and we have made a more flexible schedule. We have increased the take-home dose to at least 2 weeks and at times for 4 weeks to a reliable third party when the patient cannot come because the patient may be on quarantine. That's a very important practical area. So the patient designated third party, normally we don't do this, but we have to be flexible, and telephonic support has been extended. Still, we have lots of compromise and restrictions which remain as challenges. What if buprenorphine is not available or on telemedicine you can't prescribe, obviously? The only option legally perhaps is tapentadol, but there is a risk of abuse, or one has to go into non-opioid, the usual non-opioid detoxification based on clonidine, analgesics, etc., and supportive therapy. Just touching on 2 quick controversies. One is the harm reduction lobby. Some people are saying that, okay, if you can't stop, then at least you keep on taking and keep taking safely the drug. So there are lots of ways to reduce your health risks. They're saying that, okay, you use your cannabis or you inject your drugs, but inject it safely. And this huge controversy raging right now, does nicotine help? Some recent studies have certainly suggested that smoking may actually be protective. But the jury is still out. There are studies against, and the rationale has been questioned, but all concur that from a public health viewpoint, smoking cannot, I repeat, cannot be advocated for COVID-19. I'll finish off with this saying that what happens after the pandemic. Expect a huge deluge, so we have to prepare, plan, and provide. As today's Science magazine has asked for an essay competition where they have asked people to imagine a post-pandemic world in every respect, because the world is not going to remain the same, and this will affect the substance abuse scenario as well. Thank you.
Many thanks to Professor Basu for such a beautiful insight in this relatively less talked about dimension of an addiction epidemic within COVID pandemic. So I am very sure that you must be having a lot of questions for Professor Basu, and you can very well post us your questions in the live chat which is going on. We will just break for a very short while before we connect you to the next speaker of the day, who is Dr. Shubh Mohan Singh, additional professor in the Department of Psychiatry at PGI. So we will be back in less than a minute. So welcome back, and we have with us Professor Shubh Mohan Singh, who would be talking about coping and stress management for healthcare workers during COVID-19 outbreak.
Thank you, Dr. Arpit, and I wish you all a very good afternoon. My topic is coping and stress management for healthcare workers during COVID-19 outbreak. As we all know, we've all heard of people having a bad time in COVID-19. Healthcare professionals, healthcare workers are a special group of population which have some special sort of circumstances which predispose them to certain problems. So we'll be discussing that. Most of my presentation is going to be a lot more experiential rather than data-based. There is nothing particularly very technical or rocket science about what I'm going to speak. So I would request all of you to just listen on, and maybe after that we can have some questions. So starting with what is stress? Everybody talks about being very stressed, and that everybody is stressed. I am stressed. Everyone is stressed. I hear this a lot from my colleagues. But when we ask exactly what stress is, it becomes a problem. So what is stress? Stress is basically a feeling of any kind of mental or physical tension. It is usually due to in response to a challenge or a demand, and COVID is a challenge or a demand. It is a challenge and demand to society, to institutions, to individuals, to patients. And the basic idea is that we humans, and indeed all of animal kingdom, we all face stress because evolutionarily stress is an important factor that helps us to sort of adapt, to change, and to make the best of what we have. All of us in our lifetimes have faced problems, and we have sort of overcome them. So what is the consequence of stress? This consequence of stress is to change and adapt, and it is usually through a mechanism of fight or flight response, which you all might have heard of. And stress, interestingly, is not necessarily a bad thing. It is usually, in fact, adaptive, and it is usually a good thing. So it only becomes maladaptive or deleterious when it is too overwhelming, either in quality or in quantity. So we'll discuss that a bit as well. So if you look at this figure, you can see that, stress enables an individual to sort of actually get to a peak performance, and it is only when stress, as is shown at the right side of the figure, that when it becomes too much, that you start having a problem. So what are the manifestations of maladaptive stress? So what we're going to talk about is stress in a maladaptive fashion in healthcare workers. We had a small survey that we tried to conduct, and I'm sure many of you who are healthcare professionals would have observed it yourself, that maladaptive stress leads to all sorts of behavioral, physiological, and cognitive and emotional manifestations. So for example, there is hoarding, checking, vigilance, social media consumption. You could have physiological symptoms like pounding heart, tachycardia, insomnia, which is very common these days. Cognitive, especially worry about self and family, hopelessness, uncertainty is a big problem. Guilt, blaming, and scapegoating, which we often see these days on media and other places. And intrusive thoughts and images, confusion if it gets too much, and emotional, for instance, sadness, fear, anxiety, anger, etc. So, what are the stages of COVID-19 and what could be the sources of stress in healthcare workers? I have often felt that this is not just an infective pandemic, it is also more of that, at least in India so far, is a psychosocial pandemic. That what you have, if you add a stage 0 to it, what we started off with was a stage of anticipation, where it was mostly psychosocial. There was a lot of uncertainty, there was a lot of stuff going on about COVID-19 on the social media, for instance. And it is only in stage 1 and stage 2, 3, in which we are right now, that, we are actually having stress due to preparation for the pandemic, and there is now the stress related with the infection in direct healthcare professionals, and also now finally, infection in all categories of healthcare professionals. And finally, you will have a stage of epidemic, which we are not there as of now, but we have seen it in other countries, for instance, in China or in Iran or Europe or US, for instance, where you have to make tough choices or where you have simply too much to do. And there you have what is called fatigue and moral injury, which I'll be talking about at the very end. So when we talk about mental health consequences in healthcare workers, which are presumably stress related in COVID-19, I'll just a small review that I did. That most studies that you would, if you talk about it strictly from an evidence based point of view, it is mostly short term that we have. Long term, we don't know really. But short term studies are mostly from stage 3 and 4 countries, and actually the findings are inconsistent. One would expect a lot of stress, a lot of symptoms, but frankly, and surprisingly enough, there are not many studies that show that healthcare professionals actually have so many, psychological symptoms, for example. And interestingly enough, people on the front line are actually doing much better than people who are not on the front line. So that is interesting. And the other thing is that across the world, there is a lack of help seeking from healthcare professionals towards, psychiatrists, mental health services, etc. So even though a lot of people talk about stress, but they're not really, seeking a lot of help for that. So what does that tell you? We did a lot of internal surveys. For example, in PGI, a lot of people talked about anxiety, 50 to 60%. Even more people were observing anxiety in their peers, in their family, and it was contagious in the sense that anxiety in a person around you makes you anxious. 70% were doing things differently, they were having physiological, cognitive symptoms, etc., etc. The main concerns that healthcare professionals in PGI at least were recognizing were the provision of PPE, administrative problem, being cut off from friends and family, the effects of the lockdown, perceived stigma was a big problem. We've done some work on this, and financial stress for a lot of categories of healthcare professionals. So the solutions that they themselves sort of offered were reduction in uncertainty, knowledge, more responsive administrative setups, and better role models. So what are the implications of this part of the study? This part of what I've just spoken about is that healthcare professionals are a part of society. What happens in society affects them as well. And the healthcare professionals, one would expect, are better informed, but are not necessarily making better behavioral choices. And there are barriers to help seeking. Everyone is getting affected, and psychosocial consequences as of now are as significant as health consequences. And you have a new normal where you are living with COVID-19 amidst you. People talk about a post-COVID world. We may never actually see a post-COVID world. Anyway, so when you talk about the sources of stress, so I would divide it into, health about the organizational part of sources of stress, where again, as per our own, surveys, we found that perceived discrimination with, say, for instance, a certain category of personnel, lack of protective equipment, threat of infection, stigmatization, uncertainty, role clarity, role boundaries, people who feel that they are, somebody's stepping on their toes or trying to encroach on their turf, for instance. Neglect of routine patient care, which is separate from COVID care, was also a significant proportion of, stress, and overwork and lack of respite and recreation. I've spoken about these points because these can be anticipated and are potentially correctable at an organizational level. When we talk about individual sources of stress, again, this is too long a list. I have written some of them, but mostly, it just could go on. But the important ones that we found are experience stigma, ostracization at work. Somebody goes for a cup of tea and somebody walks away. Is a source of stress for a lot of people. People feel that they're not trusted anymore. People are not trusting anyone. Worry about self and family. People who have been recipients, even in PGI, of violence and abuse from their landlords. Other people, loneliness, consequences of lockdown, impaired relations with families, IPR problems, misinformation, etc., etc. So I'm sure most of you are aware of that. And if you want, just to have a look at it, I'm sure you can come back to the presentation later and have a look. So what about, I'll come to the topic per se, which is stress management and coping in healthcare professionals. I would think that it can be divided into two parts. One is an organizational, to make a more mental health promotive friendly organization is, I think, a very, very important part of stress management in healthcare professionals and at an individual level. So we'll be discussing both of them separately. So when we talk about mental health promotion strategies at an organizational level, these are obviously easier said than done. And frankly, I don't think that they are going into the planning of a lot of institutes and even at the national level. As I've said, it is a psychosocial pandemic. What we are focusing on more is, stuff like hospitals, ventilators, stuff like that, which is all very important. But one has to understand that effectively, if you want to counter a pandemic, it is going to be based finally on the behavioral choices of population, on the behavioral choices of healthcare professionals. If one does not promote those choices, one cannot win. So those have to be, they have to be incorporated in planning. So I would think that if you talked about mental health promotive strategies in organizations, I would think the most important are appreciation of the role of healthcare professionals, a sense of conscious equality. Lots of people feel discriminated. One has to go out of the way to make them feel equal. Inculcating a sense of being part of a larger effort. Affiliation. In the army, for instance, affiliation is the most important thing. You fight because you are affiliated with a certain group. And if you do not have if you don't have a feeling of affiliation, it cannot work. Incentivization is taking place in a lot of states, for example, financial, otherwise. Positive role models are very, very important. One has to be leading from the front. Help and support are people who are working in NHE, for instance, I think lack a multidisciplinary team at the background. There has to be clear, unambiguous communication, which is the most important thing. Clear decision making, anti-stigma measures are very, very important. And I think even lightheartedly, we should all try to avoid saying anything which could be misconstrued by anyone. I think this is very important. Removal of uncertainty with regards to personal safety, income, care of family. Again, we've had few patients where I think once you are informed of the fact that you are COVID positive, most people handle it very well. What they cannot handle, frankly, is the care of their family, or that there is no organizational support to look after their parents or children or whatever. And there has to be some provision for respite and rotation, which is already going on over here. And as I've already mentioned, even though there is a lot of stress, or at least a lot of perceived stress or expressed stress, but there is very little help seeking. Now, that could probably be due to some barriers. So I think we have to work at removing barriers in help seeking, and this can be done at a personal and at an organizational level, which requires some sort of thinking. The most important thing, as I've already mentioned, is that these factors have to be incorporated in planning for any sort of organizational response to COVID-19. So what are the needs and solutions at an organizational level? Somebody just very nicely said that what healthcare professionals want is to be heard, to be protected, to be prepared, to be supported, and to be cared. So what are the coping strategies? Coping strategies can be called self-discovered. They are self-discovered and they are trained. There is specifically nothing that you could be trained. So for instance, if you're feeling stress, you could try to actively cope with it by reframing it as a positive emotional experience. For example, lots of my colleagues feel that this is a very positive experience, that they are caretaking and they're actually doing what they were supposed to do. It's a validation of a lifetime of training, for instance. Intellectualization, we've all lived and evolved with a lot of bugs in our midst. This is just one more. The evidence-based behavior, we ran a survey and a lot of people found a lot of solace in religion, spirituality, God's command, fate, stoicism, if it has to happen, will happen, requesting and seeking help from families and friends, active distraction, prioritizing tasks, problem solving, etc. Passive could be distraction by others, avoidance is avoidance. I'm not saying that each or any of them is either good or bad. It is just that all of them have to work in certain areas. When we talk about individual methods of stress management, there are some basic rules. One is to be hopeful. Stress is not always bad. Stress generally goes away if you let it, if you give it enough time. So stress is normal. It is a product of evolution. Stress is mostly adaptive. You can have these coping strategies which we just discussed. And too much worry can tire you out. Right knowledge plus emotional regulation is equal to right action. Right knowledge does not lead to right action. I've found that out too many times. And how anticipate stress, be well informed, be familiar with work. There is a lot of stress due to novelty. People who are wearing PPE for the first time may get stressed out, but once you get familiar with it, you'll get better. Be well informed, correct misinformation, limit media exposure, try not to be on WhatsApp all the time. Be aware of triggers that set it off, anticipate specific stressful situations in your field of work, work as a team, think of how you could handle it. Anticipate handling an untoward situation at home or work, and observe for stress in self. There could be your personal red flags. For example, somebody may express it as insomnia, or somebody may express it as something else. The other part is that you need to meet basic needs, for example, food, rest, hydration. You need to take breaks, switch off, and disconnect with work. I have seen many people who just don't want to get away because they feel that they're going to miss out. Frankly, this is big enough for everyone. Everybody's going to get a chance. Yeah. And you stay connected, find time to do things you love and people you want to hang out with. Set a worrying time. My good friend Dr. Uchida told me, set aside half an hour every day and you worry about whatever you want to worry about. Only at that time, try not to do it. Stick at it and this too shall pass. Again, physical activity, drugs and tobacco, etc. And finally, if you still don't feel up to it, you could look at mindfulness, relaxation exercises. We in the department have created some resources which are available. You can use them. Honor your own service, which is the most important thing, and seek help if it is needed. And frankly, all of us would love to help you, but we need to know that you need it. When we talk about possible stage 3 and 4 options, again, this is the last slide. So this has to be probably clinician administered. This I picked up from some kind of a battle fatigue manual where you have to recognize, you have to encourage rest, you have to encourage recall, reassurance, and encourage quick reintegration and return. We are not really at that stage right now, but it is possible that we have to plan and anticipate a stage of pandemic where we might have to get into stage 3 and 4 options as well. So I would again like to end by talking about the PGI coronavirus helpline, which the numbers are flashed there. We also have a PGI telepsychiatry service and we have an internal staff and resident helpline. There's a website of, there's a PGIMER Corona portal on the PGIMER website. And my email is over there in case you need any resources that we as a part of the IEC might have developed or me individually. I'll be more than glad to answer your questions or help you in any way I can. So thank you very much for your patient listening.
Well, thank you, Dr. Shubh Singh, for such a wonderful insight into stress management and coping strategies. So before we proceed further, this is your last chance to post your questions through the live chat, and we would be back very soon with a panel discussion, and the panel discussion would be moderated by an expert, a telepsychiatry expert from PGI Chandigarh, none other than Dr. Ruchita Shah. So we will be back after a short break with the panel discussion. So welcome back, and many thanks to our panel of esteemed experts, Professor Matu, Professor Basu, and Dr. Shubh Singh. And it is the time to welcome a special guest for the day, Dr. Ruchita Shah, who is an assistant professor in the Department of Psychiatry at PGI, and she is also an expert into telepsychiatry. So I welcome Dr. Ruchita Shah to moderate this panel discussion. Dr. Ruchita Shah, please.
Thank you, Dr. Arpit, and it was indeed a very insightful 1 hour spent. and all the three presentations were very lucid. So I will quickly start with the questions. First, I would like to ask Professor Mattu, if sir, can you please elaborate on some simple strategies for the medical staff who directly take care of these patients so that they can assess the psychological well-being of the patients who are admitted with COVID-19?
Okay, the psychological assessment of patients with COVID is no different from psychological assessment of any other person. First and foremost, one has to establish a good relationship or rapport. Then that rapport makes the person concerned feel comfortable in venting out his or her problems. And as I mentioned in my presentation, one has to look at everything ranging from thoughts, emotions, and behavioral manifestations of stress. When there are some indicators based on active observation, then detailed inquiry has to be made from the patient and the relatives of the patient or other caretakers of the person as to what other manifestations of stress are there displayed by this person. Based on this assessment, then one can conclude whether or not this is something that can be handled simply at non-professional level or needs further assessment by a more qualified professional. I hope that helps.
Yes, thank you so much, sir. I would now move on to Dr. Basu before I come back to you, sir. You described about the experience of OST clinic, but sir, we would really like to know what are the challenges that you face and how you think these can be managed in the coming times.
Okay, thank you. Yeah, it is definitely a challenging time, particularly for the opioid substitution therapy, because as I said that we cannot stop these. These patients are pharmacologically dependent upon the medication. It's the challenges started from getting and stockpiling sufficient number of buprenorphine naloxone tablets, because although we have sufficient money and we have the supply order, but the supplier could not supply simply because of interstate lockdown. He could not get the medications. So Dr. Mattu helped and the Punjab government really helped to get into an innovative way of quote unquote getting lots of medications on loan. So I'm saying that these are practical problems. Second practical problem was how to let the patients know that this is what's happening, because it suddenly all changed, and there was hardly any time to really get ourselves prepared for this thing. And this is a general statement for everything really. So one of the ways we did it was by putting it up on the PGI website, and hence people came to know about that. Of course, even then some people had initial days of difficulties, then the message spread around. The third problem was ensuring social distancing and safety for both the patients as well as for the staff while prescribing, screening and dispensing the medications. As I mentioned, that we have got a very detailed standard operating procedures which can be read in the paper as well and in the IPS guidelines. But in general, we kind of zoned. We made some structural amendments. We made some zones in the registration area, waiting hall area, and the actual consultation treatment area. So with certain structural changes, we could make it. And finally, we took the principle of flexibility. So we started giving more medications than we normally usually do, and often and also to third party if that is designated by the patients, for a patient who cannot come at this time. So there are several innovations and flexibilities which needed to continue this service.
Thank you so much, sir, and I hope this elaborate reply will help many more to understand how the whole process works. Here there is a question, Dr. Shubhmohan, I would request you to take this one. What are the common consequences that you see as a psychiatrist during lockdown on the mental health services in general, and how is it possible to deliver the care?
Obviously, the first consequence of lockdown is that patients are not able to contact, a psychiatrist. Psychiatrists are not able to contact their patients. And the other problem is that, there are obvious problems, for example, with inpatient care, with services, so for example, like ECT and all services that were running through the outpatient department. So if you talk about our own department, you would have seen that our inpatient care obviously is a little less than before. OPDs have stopped. For example, brain stimulation services which were being run through the OPD are not running as of now. Patients, however, for instance, we've been able to get in touch with some of them through WhatsApp, through messaging, through telepsychiatry. So those are some things that we've been able to do. However, I would think that a lot more needs to be done. I was talking to a few of my friends yesterday, and I found that as we already discussed, this is a changed situation, and people, frankly, are adapting well. I mean, even patients and doctors, both sides, are adapting well. There's a huge surge, I would think, in things like telepsychiatry. There are newer methods of getting paid. There are newer methods of writing prescriptions. Lots of people were having problem in getting their prescriptions filled out and repeated. I think even that is kind of sorting itself out. So I think it's still a little early to actually reconcile and analyze and sort of organize everything that we are seeing, and generally that's how it is. So I think once the lockdown eases out a bit, we'll probably be in a better situation to look at the whole situation from a totality and make newer plans.
Thank you so much, sir, for this answering this question. And there's one more for you that I would like to pose.
Yeah.
You have told us about the resources for healthcare workers that are on, which are posted on the PGI portals.
Yes.
Are there any resources for the general public to manage themselves during this time?
We have actually tried to create a lot of stuff. Some of it is, it's all across the net. As I've said, that's why I sent my email address. I have my own YouTube channel. I don't want to plug it right now, but there's some videos and some other material on that as well. We are trying to get all of it together at one place so that it is accessible to everyone. And frankly, if you have access to the net, there is a lot of information, there is a lot of resource. Unfortunately, the problem is that sometimes it becomes difficult to sort of, differentiate the good stuff from the not very good stuff. So I would really advise everyone to just talk to their doctors or to other professionals. Try not to believe everything that you see on social media. I think that is very important. And frankly, we have our crisis helpline, we have the telepsych helpline, and we have other helplines in the institute. Those can be used. If you want any specific videos or any specific written material that I or other people in the IEC may have produced, you are more than welcome to get in touch with me on email, and I'll be glad to help you.
Thank you so much, sir. I'm sure many people would be getting in touch with you.
Yeah.
Dr. Basu, one of the viewers have posted a very interesting comment. He says that since due to lockdown, people are less exposed to cues such as friends and bars, etc., and so on. Do you expect it would have any positive effects on relapse rates?
Okay, thank you. I don't know what's exactly meant by positive effect on relapse, but I guess that the question is that what happens after the lockdown is lifted, and after the bars or the shops or things selling alcohol, tobacco, etc., they open up, right? The obvious answer to that would be that because the queues will again be there, hence we know that addiction in that sense is a disease, or at least is a disorder which has strong brain substrates or substrates in the neural circuitry. So it's not a one-day affair. What we have talked about in this 20-minute talk is essentially how to do the firefighting, how to manage the withdrawal, how to keep the patient. But that's why in my last slide I say that we will expect a tremendous amount of deluge of relapses which will be primarily these kind of what we call queue-based relapses once the lockdown is lifted. And then we need to be kind of brace ourselves, prepare our services right from now for that. That's what I would expect.
Thank you so much, sir. So instead of relaxing and thinking that people are, getting better because the supply chains have been broken, or that is what it seems apparently, which you very well showed to us that it is not so. But the time is actually to prepare ourselves and brace ourselves for the deluge. Thank you so much, sir. The next question is for Dr. Mattu. Sir, we have been having reports of suicides in patients who have been suspected or diagnosed with COVID, and what would you say about it? Like, how do we expect what is going to happen further?
Well, as I mentioned in my presentation, COVID can have sinister outcomes for some people because it does not have a cure, and therefore it frightens people. So it is understandable that some people will lose hope, become hopeless, and then attempt suicide, not only in the context of their own self being diagnosed with COVID-19, but also if a family member gets diagnosed or a close, near and dear one gets diagnosed. So it is understandable and expected that such things will keep on happening. And the only response to that from a community point of view can be dissemination of information to the people in general, and that there is hope, and also provision of services, both in terms of basic needs as well as in terms of medical and psychological needs, so that people don't get desperate.
Thank you so much, sir. So it is something that we have to prepare ourselves again for, and then deal with it. Dr. Basu, again to you. We saw that because of the lack of time, you just could browse through slides on harm reduction during this time. So we would really like to know more about it.
Okay, good. Thanks for asking this. See, right now, since we cannot, because of various factors largely related to unavailability and our inability to help these people many of these who are in the community. So this is probably not the best time to take a high pedestal and say that, okay, drug addiction is extremely bad, you should get out of it. It's fine. Yeah, we all know that it's bad. We all know it's very harmful. We all know that it's harmful for the body, for the mind, and for societal functioning, etc. But right now, our focus should be on withdrawal management when it becomes severe enough to merit medical attention. And most of the withdrawals, as I said, actually can be managed on its own or with some help. That is part A. And part B would be to maintain the people in the community so that they don't harm themselves any further. Because once they are alive, once they are well, once they are maintaining, there will always be the next day, the next morning when they can come for help, or we can try to help them. But till that time, they must remain alive. So it is very important to give out these messages. For example, do not use alcohol-based hand sanitizers for drinking. People are doing that. So that is a very specific harm reduction message, very practical, because people are using that. They're thinking that, okay, if there's nothing else, why don't we try this, or various other kind of non-beverage alcohol. That's one example. People are injecting because they can't get the chitta or the actual good quality heroin so people are using all kinds of bad stuff for injecting, which can leave them with serious infection on the best side of it, and the worst side of it, of course, leave them dead. So these are specific examples, and there are many others. So at least we should say to them that even if you cannot treat your condition, at least stay safe. Do whatever you're doing, but stay safe, and then as and when the time comes, again, a helping situation will arise.
Thank you so much, sir, for elaborating on that. Dr. Mattu, there is a practical question which somebody has posed, that we receive calls regarding stress and COVID-19 on our helpline. So this is from another institute, but we are not able to follow up these patients later on. Would you recommend how do we keep following up these patients who seek help for the first time?
I think whatever channel the patient or persons in the community are using to contact them, those channels must be kept open, alive for as long as possible. And this information must be disseminated to the public at large through all possible mechanisms so that everybody knows what to do, whom to call, when to call to seek help. So information dissemination is probably the only way out.
Thank you so much, sir. So, putting it out on media so that the lay public, it reaches the public, that is a very important strategy for continuing care. Thank you so much, sir. Dr. Shubh Mohan,
Yes.
there are you time and again in your presentation, you emphasized on this point that healthcare workers, even when they are stressed or even when they might be in need for help, most do not contact for help. So, would you kindly elaborate on how this scene can be changed?
Uh, in fact, a few people have actually written about it that healthcare, what it basically means is that there are some kind of barriers that exist between services and between people. Healthcare professionals personally should be able to access these services very easily. There are obviously problems which are related to stigma, where people feel that talking to a psychiatrist, for instance, is not something that is required. There are also, if one had to, I think the most important thing is that we as psychiatrists or mental health professionals have to, first of all, find out ways to get to people. As I've already mentioned, stress is mostly sort of self-correcting. It kind of most people are able to work it out. What people do need most of the times is some kind of the tools to be able to help themselves. So I think the first thing to do is to be able to develop some kind of modules which encompass stuff like self-help, emotional regulation, relaxation, management of sleep, management of motivation, management of training, and kind of develop a module where it is easily transmissible to everybody. The other thing is that we have to ensure again and again that access to mental health care is easy and is not something that people have to do specially. It should be something which should be accessible. It should be accessible at the premises, at as close to the action as possible. So, as I've already mentioned, we require some kind of a background, backup, multidisciplinary team, because it's people on the front line who sometimes find themselves very, very isolated, and sometimes they are responsible for almost everything that goes on. And frankly, many times they do feel that they are not equipped to handle certain things. Psychological aspects of, for example, isolation, quarantine is something that very few professionals are equipped or have any idea of understanding or managing. So all of these factors have to be sort of taught, and also mental health services have to be made accessible in-house, and the potential consumers have to be told not to worry or not to feel that there is any kind of barrier, and we are all part of a team, and that is how we have to go about it.
Right. Thank you so much, sir, for an elaborate answer. This question I would rather keep it open, because it is pertaining to healthcare workers as well as patients as well as general public. Are there specific strategies for sleep disturbances? I am sure many people from the general lay people are going to watch this. So please.
Okay. Sleep disturbance is one of the commonest probably symptoms of facing everybody these days, starting from otherwise completely normal people who are simply getting bored at home with nothing to do, to people who are either isolating or quarantined or admitted in any of those setups, hospital or otherwise. And thirdly, in areas with people with substance use problems or even general substance use, sleep disturbance is one of the very well known symptoms associated with this. So all in all, it's a very general thing, and largely because the work sleep pattern or the sleep wakefulness pattern has suddenly changed, suddenly without almost any time to prepare again, and that's one of the reasons. A couple of important things, what we call as sleep hygiene, would be try to avoid sleeping or taking a nap other than a very short nap probably during the daytime, keeping a sleeping time dedicated. Secondly, keep yourself busy to the extent possible within the limitations imposed by the lockdown, but still one can do a lot of work, physical work at home, if not anything else, then some kind of exercise, free hands in the kitchen or in the garden, depending upon what you have. So important thing is to keep yourself physically active, to keep yourself mentally active to the extent possible, to keep yourself engaged in some kind of activities which would be both physically, mentally and socially engaging. Do not use substances for bringing on sleep as such. So do not use substances as a self-medicational aid particularly. I think these are general things, and setting up a wake-up time despite whether you get good sleep or not. Set up a fixed wake-up time in the morning so that your sleep-wakeful cycle remains reasonably intact rather than the clock going haywire. These are some general points. Other people may chip in if I've missed something.
Thank you so much, sir. So these are some of the general strategies, and I am sure these would be of great help. I'm going to pose the last question that we all know that whenever somebody is detected with COVID or labeled as COVID positive, he or she has to be admitted in the hospital, and this is a very major source of stress, be it a healthcare worker, be it a layperson, and there is not enough preparedness possibly within amongst us. So what are the strategies that can be used to prepare a person?
Okay. I think the simple solution to this problem is that while we take care of the physical needs of the person, we also address the psychological needs of the person, which means among the healthcare carers of this person, somebody should spare time and talk to that person in a leisurely, relaxed manner and discuss the issues bothering that person. As I said earlier also, a good working relationship, a good rapport will facilitate that person coming out with what is bothering that person about self, about family members like young children, older adults or elders at home, or responsibilities related to finance, work, anything. Once that person feels comfortable, comes out with the details in terms of his or her concerns, then those concerns can be addressed by providing the required information, required support, organizing that required support through hospital channels, government channels, non-government organizational channels, and this will definitely help that person to feel relaxed and take care of his or her anxieties or worries.
Yeah, I'd just like to add a couple of things. There was a very nice study in Lancet recently where they reviewed this whole area. The two most important things are, one is that any kind of quarantine or isolation has to be, one has to be counseled properly as to what is the requirement of quarantine. I mean, as I've already stressed, real honest communication is the most important thing one can do. Most patients become troubled because they simply don't know what they're getting into, or whether it is some kind of a death sentence or it is something, they're going to get stigmatized or something like that. In fact, in our own experience in NHE, for instance, we've had around 60 patients so far. most of them have actually done very well. I mean, we've got only maybe 1 or 2 psych referrals or whatever. So people generally after the first couple of days tend to be relaxed and then they're all right. The important thing that that review revealed was the first thing is that whenever somebody is going to be sent into quarantine or isolation, one has to be communicated that see this is the approximate time that it is going to take. So, for example, if it is 2 weeks, it has to be communicated. Whether or not you require any kind of testing before you are able to get out. And the final thing, which I think is most important, is that quarantine isolation has to be reframed as a service to society, as something which is an altruistic act rather than an act of punishment. If it is mentioned or if it is understood as an altruistic act, most people are happy or at least satisfied or at least not that worried or distressed about going into isolation as would be the case otherwise. So I think those are the 3 most important things.
Thank you, Dr. Mattu and Dr. Shubhmohan, for answering this, and it's been a very comprehensive answer. You both have chipped in. I will take one more question, although I said it was the last one. Sir, this is very specific. Dr. Basu, I would like you to take it up. What kind of non-pharmacological treatments can be communicated over the phone to the patient? Like, can a person send a link to a video of, say, relaxation technique to a patient? And who might, the doctor feels that that person would benefit with a relaxation technique more than the medication?
Yeah. Okay, very quickly, yes, certainly I would strongly endorse that rather than utilizing too much of medications, we should try to utilize to the extent possible non-pharmacological means, and there are very good, very nice videos on YouTube and other resources, and certainly one can do that. But I would only suggest that before you send your link to your patient or whosoever, it's always good to first check it out yourself, because you never know what actually you're going to send. So that is a must. Just another quick question to the Pushpagiri Psychiatry, because I'm very grateful to Professor Roy Abraham Kalivayalin for sending it out to the Pushpagiri group, and thank you for that. I can see that there's a very good participation from Pushpagiri Psychiatry. And it's a very good question. What is your opinion on including non-psychiatric professionals in mental health care? As Professor Envik always used to say, and Dr. Srinivasa Murthy is also fond of quoting him, is that mental health is too important to be left only to psychiatrists. So definitely, yes, these are times when telemedicine, tele-psychiatry or tele-mental health really can be very well. And as I say, that other than the pharmacological part of it, lots of the other part can be very well taken care of by other mental health professionals who must be, I wouldn't say should be, I would say must be inducted in this process. Thank you.
Thank you so much, sir. I would just add a line or two on that especially about non-pharmacological treatments and those two delivered by non-psychiatrists. So here we have clinical psychologists in our own department who cater non-pharmacological treatments across video conferencing, as well as we have developed long back a self-guided relaxation technique which has an audio-video file, and it is being sent as a link to the patients whenever non-pharmacological treatment is needed. So I think it's a mixture of the old wisdom of Professor Wig with the new technology, and we have to apply the same in today's world. Thank you so much to all the 3 esteemed people sitting here. Thank you so much, and over to Dr. Arpit.
Well, thank you so much, Dr. Ruchita, for carving out this panel discussion so beautifully. And with this, we have come to an end of today's webinar. And I wish to thank again the panel of esteemed experts, Dr. Basu, Dr. Mattu, and Dr. Shubhmohan Singh. And at the very same time, I would also like to ask you, since you must be having a lot of questions with you, so you can very well call upon the PGI Coronavirus Helpline on 0172 2755 444, and you can very well pose your questions on this helpline as well. And I would also like to welcome you for this next webinar, which would be on 5th of May at 12 noon, and this would be focused on nursing officers regarding COVID-19. Well, thank you so much, and thanks each one of you for participating. We had an overwhelming session today. Thanks again. Jai Hind.